This is Steve Tucker. Hi, everybody. We're going to have a talk tonight, very casual, questions to ask your doctor or oncologist, but we're also going to flip it and we're going to talk a lot about the questions that people submitted, which have more to the treatment and questions around breast cancer and breast cancer prevention. So we'll do a couple of things tonight. Start with the questions that I think people should ask their doctor, as well as questions you have for any doctor. So sort of like a free consult and general review. Absolutely always happy to share. With that, let's do the magic of Zoom for everyone who's here, and I will share my screen and get that started. And let's hit play. And I'm going to assume everyone can see my screen at this point. I just need to move my camera. I just lost. So, 8. Here's our title topic. Apologies. I'm 1. Good. 8 questions to ask your doctor across the board. Here we are. Now, first thing, switch screens here. Apologies. We have to cover some background. It's kind of a requirement. We're going to talk about breast cancer. I always feel bad sharing the bad news. I'm an optimist, and I'm going to share a lot of success stories and things about how you beat breast cancer, how you never get breast cancer, but it starts with facts and figures. So breast cancer in Singapore is consistently rapidly increasing for the last 40 years. It's not just Singapore. This is a global phenomenon. It's not just genetics. It's actually not genetics. It's maybe 15% of cases are around genetics, and we can potentially talk about that tonight. But this graph shows that red line right in the middle, that breast cancer from 1970 to 2018, almost 50 years, has been just consistently increasing. That dark red line is the incidence rate, and it's about 70 cases per 100,000 women in Singapore at risk. This is a graphic that shows the breakdown of the number of new cases over time, and again, sort of by age groups. But you can see that in 1980 it was 25 cases per 100,000, and in the 2015 report it's up to 65. The 2018 report, it's now 70. So 70 cases per 100,000. This is the same graph. That pink line is the 70 per 100,000 that we're hitting. The other lines on the graph are other cancers like breast and colon and uterus and ovaries and lung. Most cancers are decreasing in their frequency. A lot of them, not all, the lower numbers you can see increases, but it just stands out everywhere how breast cancer is epidemic or pandemic around the world. And for Singapore, it is the most common cancer diagnosed in Singapore, the most common cancer diagnosed in women in Singapore, and it accounts for 30% of all the cancers diagnosed in women in Singapore. Now I have a little bit of good news. This is a trend of survival. And you're talking about men in blue, women in red, gray is a total. But those same time periods, 5-year survival rates, which is an average. People do better, people could do worse. But that number, the 5-year survival rate, you can see that it's gone from about 20% this is all cancers, not breast, to now about 65, coming up to 65 is a good number, 65%. Cancer is not a death sentence. Everyone always believes it is, but I'm going to show you that most breast cancer is going to be cured. certainly stage 1, stage 2 breast cancer, that's going to be cured. And that's important because there are questions about prevention and secondary prevention in breast cancer survivors. All right. I'm going to go back one slide just to show you that's the stage of breast cancer. So that pie chart, we're talking about almost 75% of breast cancer in Singapore is stage 1 or stage 2. And that survival rate is going to be closer to 95%. So most people with early stage breast cancer are going to be cured. And that's one of the first questions. We have to go through the animation. My apologies. But the first question that I would want to think about if I was going in, what do you want to ask your doctor? Actually, in retrospect, this is a question patients like to ask. Doctors don't think about it as much, but everyone wants to know, how long has this been there? Is it rapidly growing? Did it just show up? I had a mammogram last year, the year before, and they didn't see anything. And the reality is, cancers move at different speeds. They usually aren't there a long time. It wasn't as if someone would say, well, I saw on your mammogram 2 years ago or 3 years ago. Cancers can develop quickly from not feeling anything in the chest to suddenly being there. But more likely, with more mammograms, breast cancer is picked up at an early stage, and it probably hasn't been there very long. And there's that word again, stage. And that's actually something that's really important, that when you say you're talking to your doctor and you want to come away from that conversation, you want to know, doctor, what is my stage? And staging is a complex sort of set of numbers and abbreviations that doctors and medical students use really to talk to each other. Staging is meant to describe the extent of a cancer, and it's different for every kind of cancer. So the size of a tumor or the extent of a tumor, the lymph nodes involved, is different in staging for each different cancer, like lung or colon or breast. In breast cancer staging, we talk about the tumor being less than 2 centimeters, between 2 and 5, or more than 5. And we call that the tumor size, or the T stage, which is not the same stage that you hear when you're hearing, in the movies or TV, and you hear about the dreaded stage 4, or someone has stage 2. The 1, 2, 3, 4 system is a summary of 3 pieces of information. The T, the tumor, the T size, this in breast cancer, 2 centimeters up to 5 or more. T4 is a definition that it's more extensive. And then lymph nodes, N, the N portion, 0, no lymph nodes were seen with cancer. N1, just a few, maybe less than 3, or more than 3, N2. And there are different designations. And then lastly, M for metastasis, like we would learn from a scan, a CT, a bone scan, a PET scan, MRI. And it's a yes/no category. M0, nothing has spread far away, or M1. And so you want to ask the doctor, what is my stage? And that should be a universal statement that all doctors should agree upon. And that's going to be the TNM, and that turns into stage 1, 2, 3, 4. And again, 80% of the patients, maybe 75% of the patients that we're seeing in Singapore are stage 1 and 2. And it's the stage that we use to correlate to some of the other questions that you want to ask, which is, what are my chances of being cured? Aside from being high, can they be more specific? Another really important question that you want to ask the doctor, and you want to take a clear answer home on, is, what kind of breast cancer do I have? And so breast cancer has different subtypes. I'm gonna change the screen sharing because I think I'm gonna move around in some slides to make things a little more clear for people. Here's an example, and can you guys tell me in the chat, you guys can see, that we, where's my Zoom control box? That you can see this slide right here that's showing different kinds of breast cancer. It's not all one disease. Cancers are very unique. There's the chat box. Apologies. There, I can bring that. Yep, good. Thank you, everyone. Under the microscope, it looks different. And in the old days, we just used to know that it looked different. But with technology, and this is 50-year-old technology, we figured out could be hormone positive or hormone negative breast cancer. Maybe we should divide the breast cancer by before menopause or after menopause. Well, using genetics, those same pictures might look this way, and different subtypes of breast cancer exist. And for the patients who have been diagnosed, this is the most common subtyping. Not all breast cancers are the same. And we talk about some of them being hormone positive, and we talk about some being hormone negative. That means you want to ask, doctor, does the cancer have the estrogen marker or receptor on the surface of the cell? And that's an important thing because it helps us predict the future about cure, but it also gives us opportunity for medicine, like hormonal therapy. There's a second kind of marker called HER2 or HER2, and that's a growth factor that some breast cancers have just too much of. And so that breaks down into 4 subtypes very broadly: hormone positive, HER2 negative. And you can see them here: positive, positive, negative, positive, negative, negative. The ones that are negative, negative, we actually now call triple negative breast cancer because they don't have the estrogen or the progesterone or the HER2 marker on the surface. But that's still not accurate because we start to break those down now into other groups that might have genetic factors or immune therapy factors. So we still can find positive markers or abnormal markers even in triple negative breast cancer. It's a mixed bag. Triple negative means it's not one of the other 3. And it's really important, if you go back to that question, doctor, what kind of breast cancer do I have? That is important because if we just say breast cancer's breast cancer and it's all the same, we might have a curve that looks like this picture. But if you break it down by the subtype, that one curve, this one, is an average, but it's really an average of 4 different kinds of cancer where some respond better, some have better outcomes than others. But even in early breast cancer, this might even be exaggerated. I would agree that triple negative is somewhat worse than being hormone positive, but when you're dealing with stage 1 breast cancer, you're dealing with small percentages. You're still sort of like saying, "Hey, I'm stage 1. I'm in, in this good group of stage 1." You might have the most aggressive version of stage 1, but don't forget, stage 1 is still the least amount of cancer we can really kind of measure. So that's an important way to think about, that question: what kind of breast cancer do I have? Next question: do I need chemotherapy? Patients ask this all the time. Why do I need chemotherapy? Why is giving, quote, poison, giving toxic medicine somehow going to fix a cancer? And the answer is by understanding how chemotherapy works. Chemotherapy is just medicine. It's probably better to describe the medicines that an oncologist uses as anti-cancer medicine and not just chemotherapy. The way that we cure breast cancer that includes chemo is as follows. Patients first still always need surgery. They need surgery or surgery and radiation to remove the primary tumor. And then we do the staging. And that staging, 1, 2, 3, like we talked about, tells us indirectly what are the chances that microscopic cancer cells still exist in the body. Okay? Stage 1, the chance of microscopic cells that we can't see with a scan are very low, but still measurable, maybe 10%. And stage 3, it might be as high as 30 or 40%. That's 30 or 40% of patients having microscopic cells in their body. And so when people talk about the idea that the cancer came back, it's actually more accurate to say the cancer persisted. That a patient with a large tumor and many lymph nodes involved, well, if they had stage 3 and we removed what we could see, there was still invisible cancer cells floating around. And the other way we know that is the clinical trials that have been done over the last 4 decades have shown that if we just do surgery, for example, stage 3, 40% of patients have their cancer come back in a 5-year window. But if we add hormone therapy or chemotherapy, some kind of additional whole body systemic treatment, we can reduce that number typically by about 50%. And that's really important, not the 50% itself, but the numbers game. So when you're talking to your doctor, you want to ask, how did you get those numbers? Can you say that again and go slowly? Because this is how it works. If I know out of 100 women who get surgery for stage 3 that 40% may relapse, and I know chemotherapy cuts that in half, you're going from 40% to 20%. But you often hear a doctor say something like chemotherapy is associated with a 50% reduction in relapse. And this is where having someone in the office with you, bring a spouse, bring a family member, bring a recorder, ask to tape record the session, okay, or record on your phone. And what we're saying is 40% to 20% is a 50% reduction. For some patients, we do chemo and hormones, and we get more than a 50% reduction. But this is why we use chemotherapy. This is why we use hormone therapy. And the bigger picture here, we call it adjuvant therapy. It's an extra therapy or an insurance policy, a systemic treatment to reduce the risk of relapse, particularly for those patients with the highest risk, highest stage, meaning highest risk of microscopic cells being left behind. So that's sort of the background of why any therapy is given afterwards. Question 5. People ask all the time, and what you want to ask, doctor, how do I know if I'm cured? And as most of the patients know, time will tell. Cure is this magical word that a lot of doctors won't use until 5 or 10 years later. And patients like to think they know they're cured if they've had a scan. If I get a PET scan and nothing is abnormal, am I cured? It's still a matter of time will tell. The problem with doing too many scans, aside from the radiation exposure, is that the scan only tells you we didn't see anything on the day we did the scan. It doesn't tell me anything about next week or the month after. And our guidelines as medical doctors, we actually don't recommend scanning every year because it's only a single day in the year. It doesn't tell us that someone is truly cured by doing the scans. It just tells us we haven't seen any problems, time has gone by and things look good, but it doesn't predict the future. What I do, I actually ask my patients to imagine and envision themselves as being cured early on. That once we've done surgery and radiation, once you finish the primary treatment, and here's a very tricky question I ask my patients all the time. A woman may get the story will go, abnormal mammogram on Monday, a biopsy on Wednesday, surgery for a very small early breast cancer on Friday, and they're seeing me on the following Monday. The tumor's been removed from the breast, they're healing very well, and I ask, do you have cancer? And everybody pauses. You're like, oh, wait a second. I did have cancer. I don't have cancer right now. And while we still need to wait for time, I think it's really important that people begin to think in their head, yes, I had this very serious problem. And yes, it's been removed. It's in the laboratory, in the pathology department, in the hospital. And I'm now cured of cancer. And I just need to wait 5 years to prove it to myself. The reason that's so important is that if you keep thinking that you have cancer, it's a very stressful environment. And I'm talking physiology, adrenaline and cortisol. So having the confidence to know that you've done the right thing, you did your surgery and your chemos, you're done with the comprehensive treatment portion. That confidence of knowing that you're cured, knowing that you will be cured, knowing that you're in the 95% group, I think is incredibly important. But knowing if you're cured by waiting for a scan, if you're waiting every 6 months, every 12 months to say that my scan is perfect, you might be living in anxiety and fear of scans. That every day is a worrisome moment because is my cancer still there? Can I get a scan every day? What would I do? And and we all get it in medicine, but trying to de-emphasize the value of the scans helps reduce anxiety, and reducing anxiety improves health. So time will tell to know if you're cured. We will do some scans, but we try to rely on them less and less. Here's a very valuable question. Do I need a second opinion? And I think everyone is entitled to a second opinion. Breast cancer is very straightforward and well worked out. And the medical community in Singapore and abroad, breast cancer is so common and so well described for treatment that we're all pretty much using the same standard approach. The last thing anyone needs in early breast cancer is creative thinking. This is something that's automated, that there are protocols, recipes, plans. This is how we cure breast cancer. But I'll tell you where a second opinion is incredibly valuable. Pathology. The pathologist is the person who actually tells the doctor the patient has breast cancer. I often ask the patient, who told you you had cancer? And the answer is a surgeon. And then I say, well, who told the surgeon? And that's the pathologist. And you may have been referred to a surgeon because, it's a great reputation, it's a family friend, you did your research, this is the surgeon that you want. But the only person in the room who's going to say this is cancer or not is the pathologist. And everyone is entitled to a second opinion on pathology. Another biopsy doesn't need to be done. All that needs to be done is the glass slides that have the tumor on it need to be sent to a different set of eyes or have more tests run on them to confirm, hey, is this hormone positive? Is this HER2 positive? Recently, we've been seeing a lot of cases that were so-called triple negative, but when you start digging into them with the pathology department, we find other genetic markers that give us new treatment options. So second opinions should absolutely be offered. And if doctors are overly confident and say you don't need if the doctor takes the second opinion as an insult, that's a good sign that you really should consider a second opinion. Because if we know what we're doing, there's no doubt anywhere about this is my advice, this is what I believe. You can take this information and go ask anyone and see what they say. And often there might be some disagreements. In the United States, there historically was one chemo recipe that was used on the East Coast and an equal but different recipe that was used on the West Coast. They're both fine. It's sort of like, do you want English breakfast or local breakfast? They're both good breakfast. But the idea here is second opinions should be offered and encouraged, and absolutely no one should have anything to be afraid of from getting more information. And if it helps you sleep better at night, by all means, second opinions are highly valuable. What about surgery itself? Patient comes in newly diagnosed, and they often say, I have to have this. And the question is, no, you don't. I'm not saying the patient doesn't need surgery. I'm saying that you can be your own boss. You can be a partner in the decision-making process. There might be some surgical limitations depending upon anatomy, maybe a very small chest and a very large tumor, or other issues about the choice of surgery. But there are lumpectomies, which is a small operation. There are mastectomies, which is removing the whole breast. There's also preventive surgery on the other breast that may not be involved. But the choices for surgery should never be rushed. This is really important because cancer is an emotional emergency. There's no word in any language that really provokes as much fear. But cancer is not a medical emergency. Whether surgery happens this Monday or next Monday is not going to change the high cure rate in early breast cancer. And increasingly, we work as a team with surgeons and medical doctors and radiation doctors. And more often than not these days, we give chemotherapy before surgery. And by doing so, we can shrink larger tumors into smaller tumors or make them completely disappear. So there are choices for surgery. And doing those treatments before surgery has a lot of predictive power. Because as I described early on about chemo, historically we gave this chemo after surgery. And we hoped for the best that this was the right recipe. But if we give chemotherapy in advance, then we know that it was the right chemo because the tumor not only disappeared, but it might have completely disappeared. And patients who have their tumor completely disappear actually have an even better chance of cure than the high average cure rate. It sort of tells us as an in-body experiment that we got it right the first time. So there are a lot of choices around surgery. One of the other pieces to keep in mind that to remind patients not to rush to surgery is that the breast cancer genes, the ones people know about, BRCA1 or BRCA2, as well as a host of other common genes, for certain patients who have that genetic profile, they might want to have a treatment-based operation on one side. We would call that a therapeutic mastectomy, but they may have a preventive or prophylactic surgery on the other side. And if you just wait 7, 10 days, maybe 2 weeks to find out your genetic profile, you would have choice of doing one large operation, or you might still say, I want to do sequential operations. And this is important because I think women should be given the choice around surgery to say, I only want to be exposed to anesthesia once, or I only want to have one recovery. And I understand it'll be a bigger recovery or a difficult recovery, but you should have that choice. So knowing your genetic profile in advance becomes valuable. Let me scroll down to a slide quickly about those genetics. These are the ones that most people have heard about. BRCA1, BRCA2, that's called hereditary breast and ovarian cancer. Most people remember this from Angelina Jolie, the actress whose family frequently had breast and ovarian cancer, and she preventively had breast surgery before ever having cancer. But there are other genes that may influence that choice as well. And this graphic shows, and specific to Singapore, that out of a large group of women with early breast cancer in Singapore, 220 of these women who had had breast or ovarian cancer, 30% of them had an inherited susceptibility to breast cancer. Remember, DNA is not destiny. DNA, in my opinion, is not usually the cause of cancer, but a trigger or a susceptibility process for some people. And you can see in the green and blue, sure, more than half are the famous BRCA genes, but there's nearly 50% that were other genes. And just looking at a panel of 20 to 30 common genetic mistakes or susceptibility markers might influence a decision to have a preventive surgery instead of just rushing off to do a lumpectomy based out of fear. Because again, I get it. Cancer is an emotional emergency, but no one walks into A&E and says, stat, I need chemotherapy for breast cancer. So everyone can take a step back, take a deep breath, get a second opinion, get a second pathology opinion, get your genetics so that you have the most information you can have going into what's probably one of the most important decisions in your life. Here is my last question of the many sort of what you can do in a consult with your doctor. Ask if there are other patients you can speak with. Now, obviously, we follow privacy. I barely acknowledge spouses and partners unless they're in the same room together. We really work only for the patient and won't talk to anyone else until you tell us it's okay as a patient. But I also, for example, have a huge list, an army of volunteers who have been through this. And you should ask your physicians, your surgeons, can I speak to some of the patients who you've done surgery on or who have had chemotherapy? Do you know anyone who's like me, maybe a premenopausal, patient who maybe match the same ethnicity, the same lifestyle? And yes, we do, the same stage or subtype of cancer. And so it's not like we publish a list. We don't have a core of volunteers that you could go look up, but I can talk to patients, and I know that we have long-standing volunteers who have been through this and been through what they're going through. So you should absolutely ask. Just like if you were hiring someone for your business, you would ask for references. You have every right to ask to speak to other patients who've been through what you've been through, not just going through support groups, which are great, of course, but as the doctor, I know exactly your stage, your type, your choices, and I probably know at least 5 other patients who are your biological twin for this problem and are more than willing to speak with you about what they've been through. Sort of as an aside, and it's a question that comes up in the patient-generated ones. Let me pull that up as a launching point here. Nope, not supplement question. We have so many. Everybody submitted a lot of really good questions here, but there is a question about, can I get pregnant? All right, I'm not gonna find it. I'll leave this up here, but we've had, if you are premenopausal and still having regular periods and get diagnosed with breast cancer, fertility sparing, being given the opportunity to have kids after treatment should always be discussed. And I can think of 4 patients in our own practice right now who are, carrying babies to term after their chemo, after their breast cancer, during the first 5 years. The literature actually says pregnancy is protective for breast cancer. Pregnancy doesn't cause breast cancer, even though there are rare cases where pregnant women get diagnosed with breast cancer. It's not the pregnancy that caused it. So with that, I'm going to kind of pause on the first part of our talk, which, it was really and intentionally about questions to ask your doctor. How can you make the most of a visit? And I would reemphasize that's about make sure you know the stage, make sure you know the type, make sure you get offered second opinions and you don't get rushed. Make sure that you can ask openly any question that you want. And make sure that you have enough time. So, if you're being rushed, there is just no rush. It's no emergency. There's an urgency and you have to make decisions, but a few days here, a few weeks even, is not going to change the treatment with curative intent for breast cancer. So with that, we had a a different view from our marketing and discussion of around this talk. Not questions to ask your doctor, but we got a lot of questions in advance from patients that they just want to ask doctors. And so, and feel free to add questions in the chat. We can try to address some of those. But here's some of the things that came in. I have a family history of breast cancer, of many cancers. How can I prevent getting cancer and what should I do? Well, with cancer being epidemic, cancer and heart disease are the two big killers. The most important thing people can do to prevent cancer, well, I apologize. There's no one most important. To prevent cancer, you need to think about your lifestyle. There are some basics. Don't smoke. Smoking is still the number one cause of preventable cancers. Number two, consider your overall lifestyle, which means your nutrition, your sleep, your activity, even mindfulness, what we call the four pillars, because obesity and its sort of twin brother, diabetes, are becoming some of the most preventable causes of common cancers. Obesity is strongly associated with 14 different types of cancer. And actually it's 40% of all cancers and nearly 55% of female cancers, particularly uterus, ovarian, breast cancer. So this isn't one of our talks about nutrition and insulin. Insulin is the driver of a lot of disease, but maintaining as healthy a weight as you can and being active helps prevent cancer. Equally in that same vein, same thought, a simple overnight fast of 12 to 14 hours reduces the risk of cancer relapse. Being active, 30 minutes of moderate exercise 5 times a week, 10,000 steps a day. Being active reduces the risk of cancer and reduces the risk of cancer coming back. Other important aspects, certain infections are associated with cancer. So hepatitis B and C, and double check your serology for that. Get vaccinated for hepatitis B, human papillomavirus, not a breast cancer topic, but again, that's how you prevent getting cancer. Which is very different than screening, which is a different question that that we can talk about as we go on. But that's what we do to prevent cancer is diet, lifestyle, avoidance of smoking. Oh, and a reduction in alcohol. Alcohol is strongly associated with an increased risk of all sorts of cancers. Some would say any alcohol is associated with that risk, but I think that the historical recommendation of less than 7 alcoholic units for women per week and less than 14 for men is still a rational approach to reducing the risk of cancer. Next question. Why does someone get a lumpectomy and others get their whole breast removed? I think we actually covered that in the part about what kind of surgery and what choices. So I'm going to go to the next one. That's what I was looking for. Can I have kids after chemo? I'm pretty sure I knew who sent in that question, but the answer is absolutely yes. But this is something you need to talk to your doctor about from day one. We can harvest eggs and freeze them for during chemo, depending upon how young the patient is, and we see not a large number, but we regularly see women between 28 and 35 with early breast cancer. And after even 5 years of treatment, at age 40, a lot of women still have very strong active ovaries periods will come back, regular cycles. And so there's a lot we can do to preserve fertility, and there's a lot we can do to enhance fertility before treatment even begins. And remember, there's no rush. This is an urgency. You're not going to ignore it, but you don't have to make decisions overnight or over a weekend, because cancer is just not a medical emergency. It's an emotional emergency that needs to be managed in a rational and urgent, I think that's the right word, not emergent manner. What are the chances I'm going to be cured? So again, patients ask this all the time. This is all dependent upon the stage. For breast cancer, stage 1, 2, 3, the chances are very, very high. That's the thing to remember. To use USA numbers, in the US, stage 1 and 2 breast cancer has a 99% 5-year survival rate. Call that 5-year cure rate. And stage 3 breast cancers, when the tumor is extensive and in the lymph nodes, it's still an 86% 5-year cure rate. That's 5 out of 6 people in stage 3 are going to be cured. And this might shock people, and this is good news, but not good enough. 20 to 25% of our patients with metastatic advanced breast cancer are alive and well 5 years later. So there's still a lot of room to improve treatment, but cancer is becoming a chronic and frequent disease for many, which means we really have to think about how we prevent getting it in the first place and how we prevent it from coming back, or so-called secondary prevention. Patients write in all the time, can I take vitamins and supplements to prevent cancer? And what about using them for treatment? We're pretty open at Tucker Medical to complementary therapies. And I would say that vitamins, supplements, TCM, acupuncture, acupressure, Ayurvedic techniques are all welcome. Nutritional manipulation, fasting, and low carb or keto or Mediterranean or vegetarian, all these interventions are complementary therapies that can be done to prevent disease and to help during the treatment of disease. But there are some caveats. Certain vitamins and supplements can reduce the benefit of chemo or radiation therapy. So you need to be open with your care team about what you're taking or want to take, because you don't want to create a conflict between your supplements, your diet, and the medications that you're receiving. I generally think of this whole complementary world as being ideal for the prevention and the prevention of relapse. That in the throes of the middle of treatment, there's less room for that mix and match kind of approach. So one does have to be careful in that light. But most vitamins and supplements can be taken, but we need to time them with chemo. There's a lot of things that shouldn't be taken during radiation therapy. And the most important takeaway is bring it all to the office, show it to the doctor, and talk about the reasons and rationale and expectations for how these vitamins or supplements are supposed to synergize or help the treatment, as opposed to keeping it hidden from the care team. Does breastfeeding reduce the chance of getting breast cancer? There's a simple answer to that. Yes, it does. But also having more children reduces the chances. These are reducing the number of menstrual cycles is associated with reducing the overall risk of breast cancer. And if you think about a woman who may get her first period at age 12 and menopause at 50, that's a 40-year window of menstrual cycles. And if you're regular every month, that's 12 per year times 40 years, 480 menstrual cycles. But if you have 3 kids and you breastfeed all 3 for 12 months, that's about 6 years, without menstrual cycles. And that's strongly associated with reducing the risk of ever getting breast cancer. So it's not that the estrogen cycle itself, the estrogen itself is the cause of a breast cancer. Estrogen doesn't cause breast cancer. It doesn't. That's an important takeaway. That's like saying gasoline causes fires. No, you don't want to put gasoline on a fire, but itself didn't cause the fire. And it's thought that the cyclical estrogen may be a trigger for some patients, um, but it's still an association and not a cause and effect. But definitely reducing the number of cycles by either breastfeeding, having more children, reduces the overall risk of breast cancer. Do deodorants and antiperspirants cause breast cancer? The answer is no, they do not. So one of my patients asked me about this. Some patients on chemotherapy lose their hair right away, and some people don't, and some people lose it halfway through. And if you don't, the question really is, if I don't get side effects, does that mean that chemo's not working? There are some people that feel better about their chemo because they've had side effects, so they know that it was working. And if they don't get side effects, they get anxious. And the reality is, no. Everyone's hair follicles can be different. They can take different time to fall out. And also, a lot of our patients have delayed hair fall because they're doing a fasting protocol, and fasting, when not eating, just, soup and low calorie for a day before chemo, is a signal to the body stem cells, including the bone marrow, the gut, and even the hair follicle cells, to slow down. And therefore, they get less toxic effect from the chemotherapy. So we've been seeing a lot of women who don't get hair fall or delayed hair fall because they're doing a fasting protocol around chemotherapy. But as a general rule, the lack of side effects does not mean lack of effect. And that's something that comes up a lot, that we have to reassure our patients. Yes, it's working. It's definitely working. Does hormone replacement cause cancer, or breast cancer specifically? This comes from a huge set of studies in the US and Europe, of hormone replacement. And the short answer is yes, but timing matters. Giving hormone replacement right at the time of menopause seems to be more associated with a risk of breast cancer than if, say, menopause at 50 and a choice of hormone replacement at 65. That's a lower risk, not a zero risk, but you have to weigh the risks and benefits of, say, osteoporosis or hot flashes, vaginal dryness. That lack of estrogen can definitely be associated with some serious chronic long-term issues, but I think that one shouldn't rush right away to hormone replacement, because there is a statistical significant association with an increased chance of breast cancer. But again, that diminishes somewhat over time and is a complex area that really should be discussed with the prescribing doctor for hormone replacement. It's 8:50. I want to be conscious of time. Um, I'm not seeing, I think we're covering a lot of questions here. I'm gonna go with a few more, and then we're at 9 o'clock. If there's nothing else, we'll wrap it up. So, dairy products, are they associated with breast cancer, and is soy associated? Well, soy has been asked quite often. Has soy been linked to breast cancer? The studies, overall, the answer is no. Whether it's premenopausal, postmenopausal, hormone positive breast cancer, hormone negative breast cancer, there's no convincing association between soy intake and additional risk of breast cancer. That said, I think it's common sense. You don't want to go from your regular diet to something that is just overwhelming in soy. That, and you can have plenty of soy, but I've seen the occasional patient who has turned their life upside down to have soy. And I think dietary soy, edamame, tofu, what we get in our regular diet, no issue. I'm not keen on taking massive amounts of soy any more than I am vitamin C. I think one needs to think about that. But again, the published data says no major association. Dairy product is a different thing, not because of the dairy product, but there is an increase association of breast cancer with external hormones. So if you're having milk products, dairy products that the farm industry has put a lot of estrogen into, that's something that I think one needs to think about how much dairy product they have in their life. I think the risks are very small, but I think there are other risks around a lot of mass produced, again, milk products where the cows have been given estrogen or estrogen-like compounds. It's beyond breast cancer. It's more of a concern around obesity. It's a concern around metabolic health. And it's sort of beyond we could talk an hour about dairy products and health. Overall, to breast cancer, it's a hard link to make, but I think that again, we could reduce the amount of milk and dairy that we have. I think that cheese that has less carbo, I think butter is dairy and not even related to this. It's really around milk products and synthetic estrogens or growth hormone that you could ask questions about. So, paternal grandmother had breast cancer. Does that put the patient at risk? I have no kids. How can I reduce my risk? A family history of breast cancer, whether it's on mom's side or dad's side, definitely elevates the patient's risk. I think we have to talk about how much. I think it's critical that the doctor take an extensive family history. I think it's a good litmus test when you're in with the doctor. If they don't take an extended, what we call pedigree, this is simply how you do it. Do you have any brothers or sisters? And you write them down. And then you ask, are the parents alive? Mom and dad. Does mom have brothers and sisters? And you list those out. Does dad have brothers and sisters? And then to the grandparents. That's a 3-generation pedigree. And what you want to know from that is, did anyone have cancer? At what age or approximate decade of life? And importantly, did they die of the cancer? Because there are some family trees that cancer may happen frequently, but everyone still lives to 90. That's very different than a family tree where 3 people get breast or ovarian cancer and died before 50. Death before 50 from a cancer is a red flag. And what we're trying to do in a family tree is say, there's no cancer in this family, there's a lot of cancer in this family, or there might be some more typical cancers, maybe 1 or 2, but they don't die from them. And that's a poor man's judge of genetic risk. There are criteria for who should and shouldn't be offered genetic counseling and genetic testing, but it all starts with that family tree. One person in the family with breast cancer definitely is higher than a family with no breast cancer, but it may not be meaningful when talking to a 40-year-old woman who's asking, should she get a mammogram, a baseline at 40 or a baseline at 45? I sometimes use that analogy to help people decide what kind of breast imaging, because in places like the US or in any country where there's been lots and lots of mammogram-based screening, sometimes mammograms could do more harm than good. And over testing can be a problem. But if you've got a family where there's lots and lots of lethal breast cancer, and we're asking this question at 40, we were too late. Because if you've got that kind of family tree, the guidelines say you should be talking about MRI of the breast at 25 or 30. So if you've got a strong family history, don't wait till 40 or 45. Come talk to someone about personalizing your screening for cancer, different than prevention. On the other hand, if I see someone in their family tree, a 45-year-old woman where everyone lives to 90 and it's a big family tree with lots of aunts and uncles and no one's ever had a cancer, I'll still recommend a mammogram, but I'm going to give you the cautions about the risks and benefits of mammography because there are a lot more false positives than there are true positives when you're screening a whole population. And what this really is in a nutshell is personalized screening based upon family history and personal risk factors. Next question. Does wearing a wired bra increase the risk of having breast cancer? The answer is no. This question comes up quite a bit. The answer is no. Our garments of any type are not associated with an increased risk of breast cancer. Sort of what I just talked about. If there's a family history, should I go sooner? Well, it really depends on how strong the family history is. Because if there's early lethal breast cancer in the family, or breast or ovarian or pancreas cancers, or early prostate cancers, or male breast cancer in a family, then the question is better phrased, should I go for screening earlier, not necessarily mammograms? Mammograms have a lot of difficulty seeing through young, dense breast tissue. Ultrasounds are different, and all three together, the MRI, the mammogram, and the ultrasound, is a very good way to begin approaching personalized screening in individuals before the age of 40 with a strong family history. And so again, strong family history really begins, screening begins at 25. This question gets asked a lot. Do mammograms give you breast cancer for radiation? And the answer is no. Mammograms have a low amount of radiation, and the newest machines, and we have a lot of really great women's only breast centers developing in Singapore, the newest machines have even less radiation. What do I advise patients who refuse cancer treatment? Well, question as asked, I can't advise anything if you refuse treatment. How about if somebody says, I don't want to have chemo? I'm not going to kick you out of the practice. My job, and I think this is part of that 8 questions when you're first meeting any doctor, whether it's for cancer or otherwise, if you're not interested in my advice, that doesn't, if you don't take my advice, that doesn't mean we can't have a relationship. It means I'm going to give you my advice, and that's what you get when you engage with me. That patients often forget that doctors work for them. That at the end of the 45 minutes or hour-long consult, it's a transaction. You or your insurer is going to pay the doctor's office for our time and our thoughts. You don't have to buy anything. You don't have to have an operation or a procedure. What you're paying for is to get my opinion. And just because you might be adamant that you don't want chemo isn't going to stop me from saying, in my opinion, the best thing for you to reduce your chance of relapse is chemo. I will tell you things you don't want to hear. I'm not going to change my tune just to satisfy the patient's desire not to take a treatment. I need to tell you, here are the choices. Here are the risks and benefits of every choice. And if you want to take me up on it, great. If you don't, I'm here to help you in case something goes wrong. That you should still have a doctor in your corner. You want to blaze your own path, go for it by all means. Remember that you don't have to be alone, that there's a doctor, a nurse, a team behind you to support you in your decisions, even if we disagree with them. We don't recommend alternative treatments. Back to the word complementary, we know a lot and love complementary therapy and practice an integrative approach to cancer medicine. We don't practice alternative medicine. That's the rejection of everything we know. I can't help someone with that. And my last question from our patient population was, what can I do to prevent cancer and make sure it never comes back? It goes back to the first part of what we said. It's diet and lifestyle. It's it's conventional. It's chemo, it's hormones, it's targeted therapy, it's personalized genetics. But it's also diet and lifestyle. It's sleep, it's exercise, it's fasting, it's church and spirituality. It's social bonds and community. It could also be vitamins and supplements. It could be Tai Chi and yoga. It might also be other medicines like aspirin. Aspirin has a very strong role in preventing cancer. Some of the cholesterol lowering drugs have a proposed role in preventing cancer. So we think of a prevention menu as, one column of lifestyle interventions, a column of conventional medical interventions, a column of vitamins and supplement interventions. If you did it all, it'd be too much. Um, but we can look at each of them individually with our patients and say, what is it you're willing to do? And here are the risks and benefits. So that's how we make sure it never comes back. I'm gonna end. I'm gonna end by saying it's a team. Here's a quick snapshot of most of the team, and we have a great team. It would be great when we can, not spend so much time on Zoom and be face to face for our weekly team conferences. But nothing would get done without our nurses, dietitians, psychologists, and behavioral specialists, family medicine, and other physicians. So again, it just takes a team to do all of this prevention, screening, treatment, and secondary prevention. And I'm in constant awe and gratitude for our team. And with that, I think we'll sign off tonight, 5 after 9. This will be recorded and we'll put it out at some point in the near future. And thank you all for sending in the questions. I look forward to communicating more in the future. Have a good night.